Good evening, everyone. I'm Tony Segreto, and once again, so honored to be your moderator for tonight's In the Know Town Hall. We welcome all of you. Tonight's topic is one that affects many in our community and one that isn't often talked about: gastrointestinal or GI cancers. Now, collectively, they represent one of the greatest public health problems in the United States. As a whole, GI cancers are the most common types of cancers and the second leading cause of cancer death after lung cancer. And the GI cancers that we're discussing tonight, stomach, esophageal, pancreatic, and colon, account for the most pervasive and aggressive types of GI cancers. Each year, 300,000 people in the United States are diagnosed with a type of gastrointestinal cancer. Many of these cancers are often way too complex or difficult to treat with just one approach. That is why our experts at Sylvester Comprehensive Cancer Center, which is part of UHealth, as you know, the University of Miami Health System, are continually developing innovations in research and care to combat these three prevalent GI cancers. And tonight, they're going to answer your questions that you've sent in over the last couple of weeks on novel interventions, including targeted genomic and immune-based therapies, and review multidisciplinary advances in surgery and clinical care to improve patient health outcomes. It's an incredible panel, and once again, led by Dr. Stephen D. Neimer, the director of the Sylvester Comprehensive Cancer Center. He is world-renowned for his expertise in blood cancers. He's the Oscar de la Renta Endowed Chair in Cancer Research and professor of medicine, biochemistry, and molecular biology. He'll be joined by Dr. Nipun Merchant, an expert in hepatobiliary and pancreatic research and treatment, who is the Chief Surgical Officer, Vice Chair of Surgical Oncology Services, and Director of Surgical Oncology Research at Sylvester. We'll also be hearing from Dr. Wael El Rafai, a renowned surgical oncologist and co-leader of the tumor biology program at Sylvester. And also on our panel, Dr. Agustin Pimentel, a hematologist oncologist at Sylvester who specializes in colon cancer. Needless to say, it is indeed a world-class group of experts. Every time we have these experts on from Sylvester, you sort of say it's the Mount Rushmore of this area. Well, this is without question the Mount Rushmore. Now, before we start, let's go over how you can participate in tonight's conversation. After Dr. Neimer delivers his opening remarks, our panelists will answer the questions that you've submitted over the last week or so. You're also going to have the opportunity, though, to submit questions tonight during the program live. For those of you who have been with us before, you know the drill. For those of you new, please look at the bottom of your screen. You're going to see a Q&A feature there. That's where you're going to submit your questions. And all those questions submitted, by the way, will be anonymous. And we promise we will try to get as many to them as we possibly can tonight. But we have a full plate, and we are not going to waste any more time because we are going to bring in Dr. Stephen Neimer. And Dr. Neimer, it is such an honor and a pleasure to have you again, sir, and for you to take the time with these extraordinary doctors tonight to tell us about this one very important subject.
Thank you, Tony. Good evening. I'm absolutely delighted to be joining you and the panel and to have an opportunity to talk to the community. As always, I'm very proud to represent Sylvester Comprehensive Cancer Center, and especially the incredible and dedicated physicians, researchers, and healthcare workers that provide exceptional care for our patients. As you mentioned, these GI cancers, as we call them, are an incredibly serious health problem. And to some extent, it's very important to stress colon cancer in particular can be prevented through early detection and by preventative measures like colonoscopy. I'm sure we'll talk about that later. These cancers, stomach, esophagus, pancreas, colon, affect a lot of people in our community, and we're beginning to understand more and more about them. In some cases, we've identified infections that are linked to these types of cancers. In others, we know that diet can affect the incidence of gastric cancer, stomach cancer, and colon cancer. Other diseases, inflammatory bowel diseases, can be a predisposition, or chronic pancreatitis. And so you'll hear from these experts about how we understand the causes of this, the drivers of this, and how we are innovating in terms of the therapies that we provide. Tonight, each person here will bring a unique expertise, and collectively they work together on these GI cancers. Dr. Nitin Merchant is a physician scientist, a surgeon scientist, and he works on trying to identify how not only the cancer cells themselves, but the cells that support the cancer cells can either create an environment that allows us to effectively treat or can block the effectiveness of some of our treatments. His laboratory work is funded by the National Cancer Institute and is incredibly important in moving into the clinic. Dr. Wael El-Rafai is using genomic approaches and trying to develop specific targeted therapies for cancers of the esophagus and stomach. And he is a great example of pushing the bench work towards the patient, what we call bench to bedside. And Dr. Augustin Pimentel is an expert on colon cancer, and he's been working on immunotherapy approaches and other approaches, chemotherapy, and working as part, as you said, a multidisciplinary team that's addressing colon and rectal cancers. You know, you'll hear a little bit about both the promise and some of the limitations of cancer immunotherapy in this disease, but we continue to believe that we will find efforts to harvest the patient's own immune system to target their cancer. You know, in 2019, we became an NCI designated cancer center, the only one in South Florida, one of only two in the entire state. And as a result of that designation, which is the weight of the federal government and the National Cancer Institute telling us that we're a leading cancer center in the United States, we have new treatments that are available for our patients that are only available at NCI designated cancer centers. And we hope to use these new treatments to cure more patients of these diseases. So I think you'll hear from these experts. There's a lot of knowledge. We're always in the discovery mode, trying to figure more out about these diseases and how to best treat them. And I think the other thing on the clinical side is that we have an ever increasing number of patients. We see unfortunately, a huge number of patients with GI cancers. And so we have tremendous expertise and we have teams so that it's not just one physician trying to figure out what the right thing is to do. We have tumor boards and other opportunities for everyone to get together. And so we can get the best possible outcomes, which are seen at the NCI designated cancer centers via this team approach. Now I'll stop here. As you know, I can talk endlessly about the cancer center and about the amazing people that we have here. And let me also start, Tony, in saying it's always fantastic to see you here and to be helping us get our message out.
And Dr. Nimer, thank you. I am so honored to be here and really honored and excited about tonight. So let's get underway because we have a lot to get to. And Dr. Rafai, we are going to kick it off with you, sir. The question goes like this: what are the risk factors for gastric cancers?
Thank you, Tony. So the main risk factor for gastric cancer remains infection. And maybe a lot of people don't know that infection with a bug known as H. pylori remains the main risk factor to develop gastric cancer. Other less common factors may include diet and obesity, but majority of patients would have really infection with H. pylori. There are some hereditary causes, which we call familial gastric cancer, due to a mutation of one gene known as ecadherin. But again, mutation ecadherin are less frequent. So the predominant risk factor would be infection with H. pylori.
Thank you, Dr. Rafai. Dr. Nimer, you touched on this in your opening remarks, but I thought you could embellish on this a little bit. Why is it important to receive treatment at a facility that conducts clinical trials?
Some doctors see patients with all kinds of cancer, and some people, what we call specialize, and other doctors super specialize. And so not only, as I mentioned, do we work together as a team, but individuals within the team have specific expertise. So one is, what do you know about your disease? But the second is, what are you discovering? So in order to do competitive research, you really have to know more about these diseases than anyone else in the United States or in the world. You have to be among the most knowledgeable to propose research that's credible and research that can save more lives. And so the physicians in these university settings are conducting research. We're also teaching. We have medical students and fellows, and we have to keep up because these bright young people make sure that we know exactly why we do everything, and they're continually questioning what we're doing. So the environment at an academic cancer center, at a university-based cancer center, is one of continual discovery. And so the doctors that you see here are true world experts on these diseases.
Thank you, Dr. Neimer. Dr. Pimentel, welcome. We're happy to have you with us tonight. This question's for you. What can be done to prevent colorectal cancer?
Okay, thank you, Tony, for the question. So that's important to know, basically, as colorectal cancer is one of those few cancers that could be detected early and eliminated. So, patients are not suffering from advanced disease and requiring chemotherapy, among other therapies. So screening is the answer. And nowadays we start at the age of 45. So for average risk patients, that means patients who, family has no history of colorectal cancer, they don't have diseases in the bowel, such as inflammatory bowel disease, or there's other factors, contributing. So for those who do not carry those factors, we usually start nowadays at the age of 45. It used to be 50, but it was moved down to 45. So most, cancer, guidelines will advise for that. So typically is there's several options to start with screening. One will be just a visual inspection, and that's done through a lower endoscopy that is called colonoscopy. So the doctor who does it is usually a gastrointestinal doctor, could also be a colorectal surgeon, and they will look at your colon and rectum, and they would look out for precancerous lesions. These are called polyps, and if they found polyps, they will typically eliminate it at the time of the study. There are other ways also to detect colon cancer, not just colonoscopy, but in general, physicians, we prefer colonoscopy because we could eliminate precancerous lesions, and we can biopsy what we feel is suspicious if we found a mass and end up being colon cancer, and we can diagnose. But there are other stool-based studies that they can be done, such as detecting a full blood test. There are also newer, testing modalities, such as detecting cancer DNA in the stools. But if one of those are positive, then the next step will still be colonoscopy to find out what's there. So that's the way to basically prevent, by eliminating precancerous lesions or early detection. So hopefully it will be just an early stage cancer, and patients will not be needing chemotherapy later on.
And Dr. Pimentel, thank you. Dr. Merchant, welcome. Nice to see you here, sir. Thank you for joining us tonight. What is the function of the pancreas, and what are the symptoms of pancreatic cancer?
Yeah, thank you, Tony, and good evening, everybody. The pancreas, I think it's one of those organs that many people don't really think about or understand truly what it is. But it does serve significant purposes in the body. It basically has two main functions. One is called an exocrine function, in which it produces enzymes that help you digest fats and proteins and things. But it also has what are called endocrine functions, in which it produces hormones. And the most common one that people are very aware of is it produces insulin. Insulin helps control your glucose levels, and that's all controlled through production in the pancreas. So in addition to helping to digest fats and proteins in your diet, it also helps kind of control your glucose levels and impacts, diabetes quite a bit. The problem, with pancreas cancer is by the time it's diagnosed, in the majority of circumstances, it's already pretty advanced. And the reason for that is, number one, unlike colon cancer, we don't have many screening programs to look at pancreas cancer, because precursor lesions prior to cancer can't be seen, can't be visualized. The other issue is that a lot of the symptoms that develop are kind of vague and you don't really think about them too much. Things like abdominal pain or indigestion or some weight loss. I see many patients saying, oh, they've lost 20, 30 pounds, and they were happy because they were trying to lose weight. But unintended weight loss or some abdominal pain, especially if it's radiating to your back, can be symptoms. Depending on the location of the tumor within the pancreas, if it's associated with areas where the bile ducts and things are, many times your skin can turn yellow, your eyes can turn yellow, and you become jaundiced. And when that happens, for various reasons, a lot of times your urine will turn very dark in color, and your stools can turn very light in color. So a lot of those type of symptoms, if they occur, you have to be really wary of thinking about being evaluated and worked up to see if there's a mass or some problem associated with your pancreas.
Dr. Merchant, thank you. Dr. Rafai, I suffer intermittently from acid reflux. Should I be concerned about developing esophageal cancer?
So let me start by saying, intermittent, infrequent reflux, affects millions of people in the States, and everywhere in the world. It's really, one should be concerned if they become more frequent. That's to say, it's important to know how many times patient would feel the heartburn on the reflux per day, and how many days per week does he get that. If this becomes happening like 5 days a week, he is getting this, and every day 3-4 times, that's a concern that he needs to check with a gastroenterologist. And the gastroenterologist would really go and do an endoscopy. And based on the endoscopy, if the mucosal lining is normal, he would give him some proton pump inhibitor. If the mucosal lining starts to show abnormality, which we call Barrett's esophagus, which is a very, very benign lesion, but a risk factor for esophageal cancer, they can do some endoscopic treatment and patient would go back home on the same day. They can remove this abnormal part by radiofrequency ablation, mucosal resection, and patient will go back home. But in general, if the patient does not have the chronic reflux disease and does not have a histological lesion in the esophagus, which is Barrett's esophagus, the risk is pretty low. But anyone with frequent episodes must really consult with gastroenterologist to confirm the diagnosis.
Thank you, Dr. Rafai. Dr. Neimer, we're going to bring you back in, sir. You talked a little bit about this as well in your opening statements. Why is it important to seek treatment at an NCI designated cancer center? And by the way, Dr. Neimer, just listening early on to the 3 doctors that are with us tonight, they are extraordinary. Thank you.
Thank you, Tony. We're very proud of our National Cancer Institute, or NCI designation, and it's not that easy always to explain to the community what does this mean. I'll use the words of the deputy from the National Cancer Institute that came down to celebrate with us. And he said that the NCI designated cancer centers are the crown jewel in the American effort to find new cures for cancer. And so the most cutting edge treatments are available at the NCI designated cancer centers. I think people are aware that if you have a new drug, it can take sometimes even a decade to prove to the FDA that the drug works. Once it's proved, then the drug usually gets available at all places. But in the meantime, there are centers that have access to these drugs in advance. And those are the NCI designated cancer centers. And so that's one reason, is that you can get access to the latest treatment. The other is, they say that certain things in life are only as good as your weakest link. And a lot of these cancers now require coordinated multidisciplinary care. Pancreas cancer would be a great example. We feel that there are lots of people in the community that are told that there's no hope. And everyone knows pancreas cancer is a very serious disease and diagnosis. But with radiation and chemotherapy, there are people who can get surgery for cure that their other doctors in the community may tell them is hopeless. And when people lose hope, they may not even want to seek a second opinion. So for these diseases, it's very important to see the experts. it's very important before you give up hope to see somebody who's truly a world expert on your disease, or if you have family members who have been told there's nothing to do, we recommend people get other opinions, because we provide hope, and even to the extent of cures that other institutions cannot do.
Thank you, Dr. Neimer. Dr. Merchant, we're going back to you, sir. We have a two-part question. What are the risk factors for pancreatic cancer? Is it hereditary?
Yeah, so the majority of pancreatic cancers is not hereditary. There are some components that are hereditary, but that's less than 5% of pancreas cancers that occur. If you have a family history of pancreas cancer, you are at increased risk of developing pancreas cancer, and you should see your doctor about potential screening programs. And there are certain genetic mutations. A lot of people are familiar with the BRCA mutations. They link them primarily to breast cancer and ovarian cancer, but if you have a BRCA mutation, you're also at higher risk of developing pancreatic cancer. So that's something that's important to remember. And, we are one of the only sites in all of Florida that are part of an international consortium that is actually looking at high-risk family members of high risk for pancreatic cancer by putting them on screening programs, collecting their blood, collecting their genetic information in an effort to identify early biomarkers of development of pancreas cancer. Other than these small percent of cases that are hereditary, other risk factors include smoking is a significant risk factor, diet, meaning obesity. All of these GI cancers are actually, you're at higher risk in obese populations. Chronic inflammation of the pancreas, especially if you're a chronic alcoholic or you have chronic pancreatitis, is an increased risk factor for pancreas cancer. And then, I want to talk about an interesting one, which is diabetes. There is some link between diabetes and pancreas cancer, and there's an incredible amount of research ongoing right now. So normally diabetes occurs at two different ages. Juvenile diabetes occurs when you're a child, and adult onset diabetes occurs as an adult, but usually occurs between the ages of 30 to 50 or 55. Which is very common. And at that point, you're not really at risk of developing pancreas cancer. However, a patient that's much older, who's say 70 or 75, has new onset of diabetes, you have to seriously start thinking about evaluating for pancreas cancer. And that's something that's not known even amongst primary care physicians and things, because usually diabetes does not occur at an older age. So when that happens, and we see it all the time, people come in, they're 70, 75, and they say, oh, I was diagnosed as a diabetic 2 years ago, and now 2 years later, they have pancreas cancer. So the link between that older onset of diabetes and pancreas cancer, we don't fully understand yet. But if you are an older person and you have a new onset of diabetes, you have to really start looking and screening for pancreatic cancer also.
Thank you, Dr. Merchant. Dr. Rafai. A two-part question here. Why are GI cancers so prevalent in South America and China compared to other parts of the world? And does diet and lifestyle have significant factors in this?
Yeah, so I think when you speak about South America and China and the risk of GI cancer, you probably mainly mean the stomach cancer or gastric cancer. And there are reasons why we have a high incidence in Latin America or South America and China. And the main reason for that, unfortunately, they have endemic infection with H. pylori. So this is really endemic in these parts of the world. And this infection by itself is precancerous and can lead to precancerous lesion, which can progress over time. Remember, people who got infected with H. pylori, they get so during their childhood. So they may be, when they start 3, 4 years old, 5 years old, they get infection. Stays with them all their lifetime. So they have 50 years of infection that has gone untreated, and this infection would lead to inflammation of the stomach and will lead to the development of gastric cancer. It's unfortunate because this can be treated with antibiotics if we know that patients are infected in this highly endemic area of the world, but this is not the case. If you speak about other GI cancer, as Dr. Merchant mentioned, obesity is is a major risk factor for many GI cancers. So the obesity and then the diet. So the high-fat diet, people are eating, saturated fat, grilled food, saturated fat diet and grilled food and grilled meats and so on. Diet by itself really increase and obesity increase the risk of all GI cancers. So a healthy lifestyle would go a long way for reducing the risk of all GI cancers and other cancers as well.
Thank you, Dr. Rafai. Dr. Pimentel, what supplements can I add to assist with chemotherapy for pancreatic cancer?
Oh, Tony, what a question. So the truth is there's nothing proven through, randomized clinical trial that specific supplements are gonna lead to better outcomes, but what I tell patients in clinic overall when they're getting chemo is key to be healthy. It's key, to be healthy, try not to lose weight. I usually link my patients with an oncology, nutritionist. We share clinics. They see the patients along with us. They counsel them on nutrition, do's and don'ts. So we work as a team with nutritionists and other ancillary services that we have at Sylvester Cancer Center. So eating healthy, staying active, exercising, good sleeping habits, and avoiding carcinogens, such as smoking and so on, will, might be linked to better outcomes. But specifically, this is not a specific supplement that would tell, okay, yeah, this is, you'll do better, you'll get better survival outcomes. So, but I'm a believer that yes, all what I mentioned, it helps and support the patient to tolerate the treatment better, and tolerating the treatment better means, probably achieving more of a complete of their treatment that we discuss in clinic. And after many times, patients are getting chemo and they're getting radiation, and then here comes the surgery, right? So we need to feed patients if we can, and that comes with, healthy habits, including diet.
Great, Dr. Pimentel, thank you. Thank you for setting us straight here. Dr. Rafai, we're going back to you. Can you tell us about any promising preclinical trials underway in gastric cancers?
Yes, so I think you mean preclinical trial, what we are doing in the lab. So several laboratories, including my lab, and we are working on some preclinical studies, for example, testing based on the genomic sequencing data that we have and the gene profile of tumors in patients. So we have identified some nodes of signaling or some important hubs which control the cancer cell survival, and we try to target them. And some of the genes involved in that, it's a group of genes that we call cyclin-dependent kinase inhibitor, which is CDK1, CDK2, CDK4, CDK6, it's a family. So we are testing these inhibitors now because they control the cell proliferation and cancer cell expansion. And we are trying to do not only in vitro, but also we have the ability to do patient-driven tumor xenografts. So we have the tumor samples from patients that we can grow in mice, patient tumor xenograft, and test these inhibitors, whether a single agent or in combination with some of the existing therapeutic modalities. So there are some existing chemotherapeutics. We try to figure out if a combination would do better. Other also preclinical studies are involving testing STAT inhibitor and MEK inhibitor in GI cancer, not only gastric, but also pancreatic cancer and other cancer, and trying to figure out a way if we can optimize and the treatment and have some kind of synergy when you combine immune therapy along with some chemotherapy or with targeted therapy based on the patient sequencing data. So these are all preclinical studies that we are carrying in my lab and many other labs, and are hopeful that we can move some of these concepts into future clinical trials for stomach cancer and other GI cancers too.
Thank you, Dr. Rafai. Dr. Neimer, this was just sent to us. Can anyone come to Sylvester for diagnosis of stomach issues?
Yes, Tony, that we have a very strong gastrointestinal group both within the Department of Medicine and the Department of Surgery. And so anyone who's concerned wants screening colonoscopy or wants to see somebody about heartburn or things like that, we have a large group of attending physicians who can see patients. So the answer is yes.
Great, Dr. Neimer, thank you. Dr. Pimentel, are there clinical trial opportunities in Sylvester for patients diagnosed with colorectal cancer?
Yes, certainly they are. I am a clinical investigator, and we have, from phase 1 to phase 3 trials, and that, specifically in the arena of phase 1 trials, we have, several studies which includes patients with colorectal cancer. Okay, so those patients who are failing standard care therapies, they go through, probably 2 lines of therapies, and they're progressing, they're not responding to their treatments. We screen them. We have a pretty strong, comprehensive phase 1 group here, where we screen them for potential studies in colorectal cancer. So, and this, includes studies with novel immunotherapies, such as oncolytic viruses, which these are viruses that, we treat patients and they infect and kill cancer cells. Sometimes they're viral vectors. That means these are viruses that they carry inside specific target therapies that deliver within the cancer cells, or is digested by an immune system, so they can recognize, specific antigens that those cancers have, to see we can wake up our immune system and attack, the cancer cells that the patient has developed. So, and as we open studies, we have studies that are closing. So what is it available now? It probably is going to be different in 6 months and a year and so on. And we have also phase 2, phase 3 studies in colorectal cancer. We have also a large pipeline of studies that are coming on board in colorectal cancer that, we're eager to open to offer to our patients.
Great, doctor. Thank you so much. Dr. Merchant, this was just sent in as well. I don't think gallbladder cancer is as prevalent as the GI cancers, but are there any protocols offered to those who unfortunately have this type? Is this not considered a GI cancer due to its rarity?
Yeah, that's a very good question. So it is considered a GI cancer. It is part of the GI tract, and you're correct. It's extremely rare. It doesn't happen often. And unfortunately, it's another one of those cancers that by the time it's diagnosed, a lot of times it's pretty advanced. We actually do have a couple of clinical trials open, especially for early stage gallbladder cancers. What happens many times is people have right upper quadrant pain, which is very common with gallstones and things. And one of the most common operations in this country is actually removing your gallbladder for gallstones because of the pain that's associated with it. And many times in the community, it's unrecognized that it's not really gallstones, but it's actually gallbladder cancer. So we see a lot of patients that have had their gallbladder removed outside, and in the final pathology, the diagnosis comes back as cancer. So we actually do have several protocols and trials available for those patients with gallbladder cancer, which would be treated with a combination of chemotherapy as well as surgery to remove that area of the liver where the gallbladder kind of resides.
Great, Dr. Merchant, thank you. Dr. Rafai, and you mentioned this already before, I recently recovered from H. pylori infection, making me more susceptible to GI cancers. What lifestyle changes can I make to decrease my cancer risk?
First, let me say that I'm so happy that they got rid of the H. pylori. They removed one of the risk factors for gastric cancer. And the good news, once you treat for H. pylori, the risk goes, significantly low for the developing a gastric cancer. Then what can be done in addition to removing this risk of treating H. pylori is the lifestyle, which means we talked about it, exercise, eating healthy food, and living a healthy life. I think this will go a long way. So avoiding grilled food, avoiding high-fat food, and then exercising regularly, being active, and reducing weight. This will really decrease the risk, not just for gastric cancer, but for GI cancers and many other cancers as well. And of course, avoid smoking. If you are a smoker, stop smoking. Yeah.
Well, Dr. Rafai, we're going to stick with you because this follows up with that question. Can H. pylori be spread by family members within the same household?
Yes, it does. So what happened, we have to remember how H. pylori is transmitted. It's not airborne, but it's transmitted through food. So people sharing the same plate, sharing the same cup, eating from the same plate, using the same spoon, using the same cup. So the bacteria can be transmitted through this way and get into their stomach and infect their stomach. And that's why H. pylori, when one family member is diagnosed with H. pylori, it's really advised to screen the rest of the family member to figure out if any of them is infected and if the whole family needs to take the treatment or not.
Thank you, Doctor. Dr. Merchant, you mentioned this a while ago. I wonder if you could kind of embellish on it. Is diabetes associated with pancreatic cancer?
Right. So as we were talking about earlier, it is associated with pancreas cancer, primarily in the older population. Generally, it's not considered a risk factor just having diabetes. If you have juvenile diabetes or if you have adult onset diabetes at a younger age, less than 50 or so. But as I said, if you are an older person, generally over 60, 65, 70 or older, and you have new onset diabetes, there is a link to pancreas cancer. You definitely should start screening for pancreas cancer. It may not be readily apparent or present, but we have several screening programs for people like that. So, and actually national and international clinical trials that are looking at screening programs in high-risk people that have late onset diabetes.
Thank you, Dr. Merchant. Dr. Rafai, how are you using gene sequencing to advance research in gastric cancers?
So gene sequencing is really important to figure out what are the genes which have become abnormal. Meaning is it could be a gene mutation that is very important for developing or promoting the development of cancer by accelerating the way a cell is expanding and proliferating. And it could be the gene itself is expressed or is occurring at a high level, whether it's amplified or the gene RNA itself is very high. So it's very important for us to build a network with what are the genes that are affected in the tumor sample, and based on this gene expression, we can start building up what we call transcription network or signature network, figuring out which important hubs are controlling this cancer cell or are controlling this tumor. And then by finding which hubs are important, we try to develop treatments that can target the genes in this hub. So it's really very important for us to figure out what is existing in a tumor sample and what kind of gene mutation or gene amplification do exist to start to stratify them for a treatment that can target these specific genes. And there are examples, for example, speaking, if we take it from breast cancer, patients who have amplification for HER2, they receive trastuzumab, and similarly, patients with gastroesophageal cancer who have amplification of HER2, they respond much better if they receive trastuzumab, which is a kind of treatment that inhibit the function of this amplified gene. Just one example I'm trying to give here.
Thank you, Doctor. Dr. Merchant, can high-density ultrasound waves be a treatment for pancreatic or liver cancer?
So I believe what the question is asking is there's a treatment called HIFU, in which tumors are treated with high-frequency ultrasound waves. That actually has been shown to be effective for prostate cancer and sometimes some bone tumors, but it cannot be used in the liver or the pancreas or other GI cancers because it can affect the organs in a way that can be detrimental. In terms of the pancreas especially, it can't be used because one of the issues with the pancreas is that it wraps around major blood vessels that supply blood to the liver and to the intestines and things. And using these ablative methods can't be done near these major blood vessels because if these blood vessels get damaged, it's a big problem. You can't live without these blood vessels.
Thank you,
So
Dr.
it's effective in prostate cancer, but it is not. It can't be used for other GI cancers at the current time.
Understood. Understood. Dr. Pimentel, this was just sent in to us. How have recent years' developments in large-scale studies changed your advice on prevention, diet, and lifestyle as regards to gastro health?
Well, I think we spoke briefly, with Dr. Rifai, how, environmental factors do influence in the risk of developing gastrointestinal cancers, right? From stomach cancer, pancreas cancer, and also colorectal cancer, right? So there's a lot of metabolite carcinogens, such as processed meats, that are not recommended, and that can lead, has been associated with increased risk of developing such as colorectal cancer. So avoiding those is key. A diet with high vegetables, fruit, which they have antioxidants, are key of of each meal, and plus having other factors involved, such as avoiding obesity, exercising is key, and so on. I don't know if that's the question they had. Or
Great. Thank you, Dr. Pimentel. Dr. Neimer, why is Sylvester unique to the care of patients suffering from these diseases?
Well, Tony, I'll answer that and try to just briefly address two of the questions in the chat rooms as examples. So one, someone has asked about whether they could have microscope slides looked at Sylvester. And the pathologists at Sylvester are specialized in cancer and specific types of cancer. So for instance, in colon cancer, the depth of the colon cancer in terms of whether it's all the way through the wall of the colon, up to the wall of the colon, and what part of the colon is invaded, that can determine what's the subsequent treatment, whether the lymph nodes have a disease or not. And so it's very important to have pathologists that can distinguish these different lesions and come up with the right staging and therefore the right treatment. And there's also a question about someone who has two relatives that have the same type of gastric cancer. And so it would be important to do genetic testing and see whether there is something in the family. So we call it the germline, which means the genes that you're born with, that is predisposing somebody. And if there were something, probably you'd want to get the screening endoscopy done more often and other means of trying to detect cancer early. So it's not just the doctors and researchers that you see here tonight, but also our geneticists and genetic counselors, our pathologists, the radiology. Two people can look at the same painting and come away with different impressions. And the same when you look at CAT scans and MRI. So we hold each other to a very high standard. And that goes from the beginning diagnosis, to the doses of treatments that are used and the sequence of things. And that's why Sylvester and similar places are so important.
Great. Thank you, Dr. Neimer. Dr. Merchant, this was just sent in to us as well. I have esophagus cancer and I'm getting treatment at Sylvester with Dr. Gilberto Lopez. Since 2017, my cancer has now spread to the abdomen. And as of today, I'm receiving immunotherapy and chemo. Is there anything new to fight this?
Well, first of all, if the cancer had spread since 2017 and you're still doing well, that's a very, very good sign, because that's not as common. And the fact that you are receiving immunotherapy is actually a very, very new kind of approach towards treating this. In 2017, it was not known that immunotherapy is effective in gastric or esophageal cancer. This has been one of the recent findings that has shown its efficacy in certain types of cancers. And the fact that you are getting treated with that, you're really receiving cutting edge treatment. The other thing that's unique to our center is almost every patient who has advanced disease that has spread to other areas. We talked about genetic testing. All of these tumors get tested and sequenced for looking for specific genetic mutations in their tumor to see if the tumors do have genetic mutations, and we have targeted therapies that can attack those mutations that are defective in the tumor. Then these are also cutting edge treatments that are not available at most centers and would be available here.
Great. Thank you, Dr. Merchant. Dr. Rafai, immunotherapy has been successful in the treatment of melanoma, lung, colorectal, and head and neck cancers, among others. Can it be effective for stomach and esophageal cancers as well?
So I think Dr. Merchant alluded to the answer about that. So immune therapy has been now tested in several clinical trials for gastric cancer, esophageal cancer. We are still, evaluating the response and what is the best way for combination with immune therapy, because we know that immune therapy very often need to be combined with some sort of other treatments. So this is being done now and being evaluated in several clinical trials, and for gastric and esophageal cancer, and if patients qualify for them based on their cancer type and the pathology and everything else, then they would qualify for entering clinical trial and be treated with immune therapy.
Thank you, Dr. Rafai. Dr. Merchant, back to you. What types of pancreatic cancers are there?
Right. So the overwhelming majority of pancreatic cancer is something called adenocarcinoma. These are tumors that form from the exocrine cells. These are cells that produce the enzymes that help digest fats and proteins and things. So 90 to 95% of pancreatic cancers are that type, and that unfortunately is the more aggressive type of pancreatic cancer. 5 to 10% of pancreatic cancers are what are called neuroendocrine tumors. Those are formed from the cells that produce the hormones that control insulin and other hormones. Those actually are rare, but many of those can be very slow growing and very indolent, meaning that even if you have the tumor and it's advanced and it's spread to other areas, you can actually live for years with those tumors many times, because many times they're so slow growing and indolent. Unfortunately, the majority of pancreas cancers are the more aggressive type, or the adenocarcinomas, and those are the ones that need to be treated, need to be identified early to really have effective outcomes.
Thank you, Dr. Merchant. Dr. Pimentel, what are treatment options for patients with newly diagnosed colorectal cancer?
Okay, good. So, so we divide a little bit there as to if this is a rectal cancer or it's a colon cancer, right? So, and also as we do in all solid tumors, we stage patients prior to treatment. Treatment could be either surgery, chemotherapy, and so when we stage and we determine how advanced is the disease, if it's just local, if it's just a cancerous polyp, it has invaded through the wall, it has, going to the lymph nodes, or has spread to liver or other organs such as bone or lung. So, for example, in colon cancer, when the patient has localized disease, basically the treatment upfront is surgery. Okay, it's what is called a colectomy or partial colectomy. It is, they remove the part of the colon that is ill with the cancer, and then the pathologist would tell us the final stage, how advanced was the tumor there, right? So, and then, so the patient typically first meets a surgeon. If there's no evidence of metastatic disease, surgery takes place. And then medical oncologists like me will see the patient after surgery to evaluate the risk of the patient developing recurrence, okay? And that's kind of based on findings that they're reported under pathology, and including the stage and some molecular factors, right? And so some patients will require chemotherapy, what we call adjuvant or preventive chemo, which we can do for 3 to 6 months. But some patients might be early stage, such as stage 1, stage 2. They might not have any high-risk features, and they might be placed on surveillance. So they'll be placed under a survivorship program in Sylvester Cancer Center. So on the other end, rectal cancer, when it presents and it's at least, I would say stage 2, stage 3 would require radiotherapy because the pelvis is an area where the tumor can recur. And sometimes it's not easy to go and remove a tumor down fixed in the pelvis. So studies have shown that when we provide what we call prior to surgery, that is called neoadjuvant, we give them a course of chemo, sometimes chemo plus radiation, and sometimes we do chemotherapy and then chemo radiation. And then we present these cases in our rectal cancer tumor board that we meet every week. We review the presentation, we review as cancer done every 2 months, and then we determine when is the best time to go and resect. So that's the difference between colon and rectal cancer. That rectal cancer requires radiotherapy prior to surgery along with chemo, and then the patient had surgery, and then they meet back with us, medical oncologists, to review how well the patient did, and we restage the patients to see if they need chemo afterwards. So,
Dr. Pimentel, thank you.
and sorry,
Would you like to add something? Please go ahead.
yeah, just to add, if the patients have metastatic disease, then it depends on the burden of metastatic disease. So if they have a few metastases spread outside, the primary site where the tumor is located, such as the liver, which is #1 organ for colorectal cancer. So if the patient has 1 or 2 lesions or 3 lesions, then we start involving our surgical oncologists, such as Dr. Merchant, and we present, again, we work as a team, we present these patients in tumor board, we define resectability, and is if the tumor could be removed from the liver, and then we dictate multidisciplinary, plan of care as to chemo, surgery, radiation, and we represent, with the outcomes as to what to do later on. Wonderful. This is just some examples.
Right. Thank you so much. Dr. Merchant, this was just sent in to us. My father passed away from stomach cancer, and my cousin was just diagnosed with the same type of cancer, a gastroesophageal junction in cardia. Is there a test for this?
Yeah, I think Dr. Neimer alluded to this earlier. If you have a strong family history of similar cancers, I think it's very important to come in and get tested for genetic testing, the germline testing that Dr. Neimer was talking about, because it could be that this is a hereditary form of cancer. And if you're born with certain mutations in your genes, then you may be at very high risk, especially when you have a strong family history of at least 2 or more first-degree relatives developing the same type of cancer. It's very important to come in, see a genetic counselor, get genetic testing done. They do a whole family screening. And if that's the case and you're tested and you do have a certain mutation that puts you at high risk for these cancers, then you're put on a screening program. And more importantly, it's important for all your other family members to know and come in and get tested also, because it could be a familial form of these type of cancers.
Thank you, Dr. Merchant. And Dr. Pimentel, this just sent in as well. What are the risks of chronic diverticulitis, and is there an effective treatment for this condition?
Okay, so that's not an oncological, disease. So that's inflammation of the diverticulum, which are little small bags that come out of the colon, typically in the left side. And I will typically consult a colorectal surgeon to see if that area that is ill in the colon could be removed.
Yeah, let me tackle that as a surgeon. So chronic diverticulitis can occur. Usually if it occurs 1 or 2 times and it's a mild form of it, it can be treated with antibiotics. And if it goes away and it doesn't come back, then generally speaking, you can just treat with antibiotics. However, if you have chronic diverticulitis and these episodes keep recurring, sometimes it can be very severe and cause a lot of problems and complications. In those circumstances, it's better to have that segment of the colon which this diverticulitis is occurring in chronically, have that removed surgically, so it kind of tries to eliminate the problem. Another thing to remember, though, a lot of times people are diagnosed with diverticulitis. It's important to have a colonoscopy because sometimes colon cancer can present like diverticulitis type symptoms.
Wonderful. Dr. Merchant, thank you. And thank all of our panelists. That was our last question of the night. Before we close this evening, I think it's important. It's been remarkable. It really has been. that we bring in Dr. Neimer for his final thoughts. And again, Dr. Neimer, you said going into this that these were extraordinary doctors. I think it's proved that point pretty quickly tonight. Thank you.
Thank you, Tony. It's the details matter. There's a lot of other sayings that, but fundamentally, in terms of some of the questions, please ask your doctor what's right for you. Obviously, things like cigarette smoking or obesity, drinking alcohol can be a risk factor for certain cancers. And so there are lifestyle changes that people can put in place, and they're not easy, but there are ways that we can help. So not only physicians and things, but we have a lot of what we call support services, nutrition, acupuncture, massage therapy, both for people with cancer and for people that are trying to live a healthier lifestyle. And so we want to prevent cancer. That's the best way, is to prevent it in the first place. And when people present with cancer, we want to treat it as effectively the first time around. And so I hope that people on the call have had a chance to see these experts discuss the nuances. Another general rule, nothing wrong with getting a second opinion. And as a physician for many decades, if you're worried that your doctor is going to drop you if you ask for a second opinion, that's exactly the kind of doctor you should be dropping, because we all want to hear from our colleagues when there are difficult decisions to be made, that people get the right advice and get the right treatments. So, thank you very much. Each of these cancers, probably we could devote an hour to one by one. We appreciate everyone's patience, and we will get back. I think maybe you're going to say this, where we will answer all the questions, and we're here for the community. Someone asked about Obamacare. Yes, if you have Obamacare, we are happy to see you. And so we're all out in the community trying to do our best.
Dr. Neimer, thank you. Strong, strong words of wisdom. Well, I hope you all agree this was an extraordinary hour with not just the top experts in their respective fields, but passionate individuals who every day strive to not just make their patients in their community better, but make their patients in their community be hopeful. Please remember that a full recording of this program will be posted online. Look for that link in coming days. And in a moment, you're going to get a survey about tonight's town hall on your screen. Please just take a minute. It's even less than a minute to submit your feedback, because what that'll help us do is understand your interest, and it'll improve our program as well. As always, we wish you and your family good health and a very, very happy Thanksgiving. And remember, we are always very thankful to say it is all about the you. Good night, everyone.